Hello, my name is David Murray. I'm the Associate Director for Prevention and the Director of the Office of Disease Prevention at the National Institutes of Health. I'm pleased to welcome you to the first of three 2025 ODP Early Stage Investigator Lectures. We created this lecture to highlight early career prevention scientists who have not yet served as a principal investigator for a substantial NIH-supported research project, but who have made outstanding research contributions to their respective fields and are poised to become future leaders in prevention research. Before we begin, I have some housekeeping items. You can submit questions during the webinar via the Q&A pod. You'll need to open the pod by hovering your cursor at the top of the Teams window and then clicking on the Q&A icon. We will open the floor to questions at the end of the lecture. The slides and video recording will be posted on our website in the coming weeks, and you'll be able to access them. We're excited to present one of our 2025 awardees, Dr. Neeli S. Shah. Dr. Shah is an assistant professor of medicine and preventive medicine and a preventive cardiologist in the Bloom Cardiovascular Institute at the Northwestern University Feinberg School of Medicine. His research program focuses on identifying the unique factors that influence cardiovascular and cardiometabolic health among Asian American communities, including the social determinants of disparities in cardiovascular outcomes in U.S. Asian populations. In this lecture, Dr. Shah will outline the science of cardiovascular disease prevention among Asian American populations. His exposition will include emphasizing the epidemiology of cardiovascular health across disaggregated Asian communities, characterizing upstream social and structural factors that influence cardiovascular disease risk in these groups, and discussing evidence for adapted clinical and community-based prevention interventions that build on the unique characteristics of Asian populations. Please join me in welcoming Dr. Shah.
Good morning, and thank you, Dr. Murray, for that kind introduction, and my thanks especially to the NIH Office of Disease Prevention for this recognition and this opportunity. It's an honor to be here sharing about this topic in my research in support of cardiovascular disease prevention in Asian Americans. And this is an area of research that emerged from my own experience and that of my family and my community. As an Indian American, I'm closely acquainted with the burden of cardiovascular disease in the South Asian population, which many of my community have experienced starting at young ages. This experience prompted my research in clinical care in this space, which I'm glad to have the opportunity to speak about this morning. So this morning, I'll address three key questions, as you've heard, to help us better understand the experience of cardiovascular disease and prevention Asian Americans, and how to promote equity in cardiovascular disease prevention for this group that has been underrepresented in health research. So first, briefly, I'll speak about how cardiovascular disease and cardiovascular health are experienced by Asian American populations. Second, I'll speak on what upstream social and structural determinants influence cardiovascular risk in Asian Americans. This is one focus of my research program to better understand potential social exposures that contribute to cardiovascular disease risk and identify upstream strategies and modifiable exposures that may promote cardiovascular health in Asian American populations. And third, we'll speak about the interventions that may effectively and equitably prevent cardiovascular disease for Asian American individuals. So first, briefly, some information about the epidemiology of cardiovascular health and disease in Asian Americans. And as we dive into this discussion, the important context to know is how health data has historically been collected in Asian American populations, if it's been collected at all. In heart disease-related data, we are only just starting to be able to understand the health of Asian American populations because the data we have are only recently allowing us to do that better. Before, if there was an opportunity for a study participant or a patient to identify as Asian, they really only had one choice, a single category called Asian. And most of the time, this wasn't even an option at all, and people who identified as Asian were grouped into a, quote, other category. Now, research studies and federal data are increasingly allowing participants to identify as one of multiple individual Asian ethnicity groups, which was mandated in part in federal data sets by the Affordable Care Act. It's still not perfect, though. Most clinical research still identifies any person of Asian background simply as Asian. When Asian subgroups are identified, they're most commonly only the 6 largest Asian American subgroups that are considered, which are listed here. And there are many more groups that are not frequently listed. Where do data from Asian populations come from in the United States? Well, these data can come from many places. There are nationally representative surveys like the Behavioral Risk Factor Surveillance System, the National Health and Nutrition Examination Survey, and the National Health Interview Survey that do disaggregate individual participants into individual Asian groups. Our vital statistics systems, including birth and death certificates, have also allowed for disaggregation of groups, as well as several epidemiologic cohorts, many of which are funded by the NIH, that are focusing on specific Asian populations, like the Masala study of South Asian populations, the MESA study, which includes Chinese participants, as well as other groups that are represented in other epidemiologic cohorts. Increasingly, we're also finding that clinical electronic health record data may be useful in understanding health status and outcomes, but most health systems still don't allow patients to disaggregate into individual self-identified Asian groups, so these data still remain limited. Identifying Asian American individuals appropriately is particularly important in the context of the rapid growth of the Asian American population. It's the fastest growing racial and ethnic group in the United States that's projected to reach over 46 million people in the US in the coming decades. The proportion of immigrants who are Asian is also steadily growing, and the Asian population is anticipated to become the largest immigrant group in the US in the next few decades. So in this year, 2025, the US population of immigrants is 29% Asian, with 43% Hispanic, 8% Black, and 18% white. Projections through 2065 suggest that the immigrant population in the US will become 38% Asian, 31% Hispanic, 9% Black, and 20% white. And here on this figure on the right, you can see that the US population of Asians is comprised predominantly of these 6 largest Asian groups, namely Chinese, Indian, Filipino, Vietnamese, Korean, and Japanese. But an additional 15% of the US Asian population includes a diverse group of individuals with origins from these listed countries. I hope this figure conveys how heterogeneous the category of Asian is, and this is a fundamental aspect of health promotion for Asian Americans. Disaggregation into individual groups is important because these groups have different characteristics that result in clinically important differences in health status and outcomes. One area where this heterogeneity is evident is in the experience of cardiovascular diseases. So these are charts showing cardiovascular disease age-standardized mortality rates from leading cardiovascular causes of death from 2018 to 2023 using data from the 6 largest Asian communities that my research group recently published. The charts show rate ratios of age-standardized mortality rates in each group compared to the mortality rate in the overall Asian group, where all groups are aggregated, meaning that when bars point to the right, mortality rates in the individual groups are higher than the overall Asian group age-standardized mortality rate, as seen on the left side of the panel for Filipino and Indian populations. And when bars point to the left, mortality rates in the individual groups are lower than the mortality rates seen in the overall Asian group, as seen on the right side of the panel for Chinese and Korean populations. There are important differences and outliers in cardiovascular disease mortality, but the key takeaway here for today is again about data disaggregation. The burden of mortality is not uniform within the category of Asian Americans, so grouping these populations into one group is not appropriate. This is another way to understand the cardiovascular disease burden of Asian Americans. This graph shows proportional mortality from ischemic heart disease in the US, meaning the percent of all deaths that occur that are due to ischemic heart disease in different racial and ethnic groups using national mortality data. You can see that proportional mortality from ischemic heart disease is highest in Asian Indian women and men compared with all other groups. 13 to 18% of all deaths that occur in Indian adults in the United States are due to ischemic heart disease, which is higher than the proportion in all other groups, including white, Black, Hispanic, and other Asian individual groups. So the burden of ischemic heart disease in particular is high within Indian and other South Asian populations. Data on non-fatal cardiovascular disease are harder to come by because there are no national registries related to non-fatal cardiovascular disease events, and there's lack of disaggregation in most of the national data that are available. So these are data that show heterogeneity and the rising prevalence of cardiovascular disease among 3.4 million primary care patients of various Asian groups in a healthcare system based in Northern California, with the Filipino patient population shown in gray, as well as Native Hawaiian and Pacific Islander patient population shown in dark red. These are the adult groups with the highest cardiovascular disease prevalence. And you can see that cardiovascular disease prevalence has been increasing across the last decade. I'll also highlight the heterogeneity in leading cardiovascular disease risk factors. These are data on the left, these are data from another Northern California health system with hypertension prevalence across age groups from age 30 to 79 years old in various Asian American populations. And across all age groups, Filipino adults had the highest hypertension prevalence, similar to the prevalence observed in Black adults, with a range of prevalence values across individual Asian groups seen in this health system. Diabetes is another strong risk factor for cardiovascular disease. On the left is a panel showing data from NHANES with diabetes prevalence that is age, sex, and body mass index adjusted. Diabetes prevalence was observed to be highest in the Southeast Asian population and also high in the South Asian population, both groups of which have higher diabetes prevalence than observed in Hispanic, white, and Black adults in the United States. And on the right are data that my research group generated showing self-reported diabetes prevalence from the behavioral risk factor surveillance system. The BRFSS data, as you may know, are self-reported. So this represents known or diagnosed diabetes. And the prevalence rates here were highest in Filipino, Japanese, and Indian adults. Now, because these data are self-reported, the prevalence rates here may be indicative or at least influenced by other factors like access to care or healthcare utilization, resulting in recognition and diagnosis of diabetes within these groups. One particular area of interest of my lab is in earlier life risk factors. In the context of sex-specific risk factors earlier in life, I'm particularly interested in the role of adverse pregnancy outcomes among women and how they influence both maternal risk for cardiovascular disease and offspring cardiovascular health. These are data from the National Center for Health Statistics natality data, in which we evaluated trends in gestational diabetes among women and Asian American groups, given the association of gestational diabetes with future cardiovascular disease risk. On the left is a graph showing data from the major race and ethnic groups, showing trends in gestational diabetes per 1,000 live births between 2011 and 2019, again using the birth certificate records from NCHS. The highest burden and the highest rate of gestational diabetes was observed in Asian American and Pacific Islander populations. On the right are the data disaggregated by individual Asian American groups, and you can see that there's wide heterogeneity. I'll note your attention to the fact that the vertical axis scale is the same on both graphs. And so you can see that there are very low rates of gestational diabetes among Japanese women, but very high rates in Indian women, where in the United States, Indian women have the highest rate of gestational diabetes of all groups. I'll also take a moment to speak about body weight, body composition, and adiposity. Now, this is a hot topic in cardiovascular disease prevention with recent clinical trial data showing benefit of pharmacologic agents for weight loss. I'll first acknowledge that body mass index is not a perfect measure of body composition and adiposity. And on the left, you see the categorizations of body mass index for underweight, normal, overweight, and obesity using standard BMI categories that you may be familiar with. Now, in 2004, a World Health Organization expert commission suggested that body mass index thresholds at which the risk for metabolic and cardiovascular complications increases are lower for Asian populations. So these are shown on the chart on the right. And notably, the World Health Organization defined these as a, quote, public health action points, and they did not recommend redefining overweight or obesity for Asian individuals. But in the years since this expert commission, many individuals working in the space have considered these as redefined categories for normal weight, overweight, and obesity. Personally, I don't think we yet have enough data to necessarily redefine overweight and obesity among Asian individuals. Nevertheless, several clinical guidelines recommend these thresholds for clinical decision-making, such as screening for diabetes in an Asian patient at a lower BMI than the BMI threshold that one might use for a patient who is not Asian. Now, there are several clinical considerations related to body weight and body composition as they relate to these Asian-specific BMI categories. Most Asian American people aren't considered overweight or obese by standard categories, so in clinical settings, they may not be recognized to be at risk for metabolic and cardiovascular complications related to body composition. Some studies of body composition in Asian Americans suggest that there are different types of adiposity characteristics, such as higher amounts of visceral or intrahepatic fat, that may worsen metabolic health. To assess the population burden based on these BMI thresholds, we use data from BRFSS to estimate obesity prevalence based on self-reported height and weight. So these are data from over 70,000 Asian American participants in BRFSS over several years. And the chart shows obesity prevalence defined as BMI greater than or equal to 30 kilograms per meter squared in the solid white bars, so based on the standard BMI category. And Asian-specific categories, the prevalence of obesity based on Asian-specific categories are shown in the striped bars, representing the prevalence if obesity was defined as a BMI greater than or equal to 27.5 kilograms per meter squared. Now, when using the lower thresholds, the prevalence is, of course, higher in Asian groups, but this begs the question, are we missing clinically significant obesity and its metabolic consequences in Asian populations if we don't apply lower BMI thresholds? Now, although lower thresholds would help identify more people who may be at risk for metabolic consequences, we would still need to reconcile this approach with using need to reconcile this approach of using a race-specific threshold, which may conflict with recent efforts to apply clinical algorithms that are race agnostic. And so there's a lot more work to be done in this space to better understand the optimal approach for evaluating and recognizing obesity in Asian American populations. Now that we've briefly covered the epidemiology of cardiovascular disease and its risk factors in Asian Americans, I want to move to understanding why this excess burden of risk factors may occur and how to address these risk factors and the disproportionate burden in certain groups. For this, I'll turn next to sharing some of my work and that of others in this field, investigating the upstream social and structural factors that influence cardiovascular disease risk and cardiovascular health promotion in Asian Americans. I imagine many of you are familiar with the concept of social determinants of health. If it's less familiar, social determinants of health can be thought of as the conditions in which people live, are born, they grow, they work, and they age. And many studies have shown their direct role in influencing health and disease outcomes. I like this figure of social determinants of health from the Kaiser Family Foundation because several salient domains are clearly depicted. But this model, I think, is somewhat oversimplified because it does not capture the complexity of how social determinants operate and interoperate to influence health and outcomes downstream. So this past year, I had the privilege to chair and lead the writing group for this scientific statement from the American Heart Association titled Social Determinants of Cardiovascular Health in Asian Americans. This was published in 2024 in the journal Circulation, and for anyone who's interested, I've shown here a QR code that you can scan to take you directly to this paper. This statement was built on a foundational understanding that the Asian American population is a diverse group that experiences considerable heterogeneity in cardiovascular health and cardiovascular disease, as we've already seen. The objective of the scientific statement was to be a foundational exposition of the state of the science, investigating upstream social and structural determinants of health that influence cardiovascular health of the Asian American population, with a particular emphasis on the role of social determinants of health across disaggregated Asian American ethnic groups. One of our tasks in the statement was to inform future research in this space. So to plan my own research activities, I like this figure, which is the conceptual framework from the WHO's Commission of Social Determinants. And it shows how many of these determinants are related and interrelated. You can see here echoes of the socioecological model, moving from the left, focusing on socioeconomic and political contexts and environments, to the right on more individual level factors. So to be more specific, on the left, which shows structural determinants that are social determinants of health inequities, these factors relate to things like public, economic, and social policies, as well as cultural factors. Towards the middle of this model, on more individual level social factors, leading with socioeconomic position and its many measures. To the right, highlighting intermediary social determinants of health, which are individual level factors that may more directly influence health, well-being, and equity. Because of its detailed nature that aligned with many of the factors relevant to Asian American populations, the writing group of this scientific statement adapted the WHO model specifically to create a conceptual framework for social determinants of cardiovascular health in the Asian American population. We particularly highlighted factors for which data have been gathered among Asian populations in the US from sociological, behavioral, population health, and clinical research. We expanded identification of structural and social determinants of health inequities in Asian Americans, including factors related to the economy, related to housing access, education access, labor policies related to equal opportunity and wage protections, health policies, including insurance access, um, reproductive health policies, and food systems, as well as cultural factors, which is a large and complex category for which a lot of investigation remains ongoing. As we move more downstream, we identified several individually experienced factors, including socioeconomic position, again, in its many measures, demographic and identity related factors related to ethnicity, gender, and social class, and spanning upstream and downstream factors, including social environments like neighborhood cohesion, ethnic enclaves, as well as individual level cultural factors related to acculturation and related concepts of English language proficiency and health literacy. We also focused on some individual level intermediary determinants, including material circumstances related to housing and transportation, neighborhood safety and built environments, as well as health behaviors related to cultural norms specific to Asian populations, as well as psychosocial factors, including stress and allostatic load, which are related to upstream factors that may incorporate the experience of immigration in Asian American communities. And we specifically highlights health system level factors as experienced by Asian communities related to quality of care, language access, and trust in the healthcare system. And spanning all levels of factors, we highlight the role of structural racism and interpersonal discrimination as experienced by Asian Americans. So to clarify, most of these upstream social and structural determinants of health are relevant across diverse populations and may not be limited only to the experience of Asian populations in the US. This model more explicitly tracks how some of these factors are related and conceptually influence cardiovascular health among Asian Americans. These are the specific domains that we highlight in the scientific statement, in part because they were the ones that have the greatest evidence base. And I won't address all of the domains we covered, but I'll highlight a few as we think about the potential upstream determinants of cardiovascular health and cardiovascular health promotion. First is the role of place of birth and U.S. nativity, which is one measure that is related in part to immigration. This is a chart from the scientific statement showing the distribution of place of birth among different Asian groups, including those born outside the U.S. versus born inside the U.S., using data from the American Community Survey between 2017 to 2021. You can see in the U.S. there's a wide distribution, with 35% born outside the U.S. among the Hmong population and 45% in the Japanese population, to about 84% born outside the US among Bhutanese and Malaysian populations in the US. Now, place of birth is a complex factor that's related to many other factors, including immigration policies, child and environment exposures, acculturation, food environments, health behavior norms, and many more. This measure does relate to a theoretical, quote, healthy immigrant effect, which is an epidemiological observation that immigrant populations have better health status compared to their US-born counterparts. Now, this does not apply necessarily universally among heterogeneous Asian populations. And at this QR code, I'll point you to a nice commentary from several of my colleagues that addresses this issue well. These are data from the National Health Interview Survey led by a postdoc in my group, Michael Hammond, who evaluated cardiovascular health scores in U.S. Asian groups stratified by U.S. nativity, specifically the Asian, Indian, the Filipino, and the Chinese groups. The cardiovascular health score reflects the burden of cardiovascular disease risk factors, with a higher number reflecting better cardiovascular health. For Filipino and Chinese adults, the cardiovascular health score was higher, indicating better cardiovascular health in those born outside the US, but the opposite was the case among Indian populations in the US. So we see that place of birth may play a role in cardiovascular health, but may operate differently in various groups. We also discussed socioeconomic status extensively, and this is, as many know, one of the most important and well-studied social determinants of health. This figure shows the distribution of annual household income across Asian American groups, and we summarized some work investigating socioeconomic status and income in cardiovascular health. The Indian households had the highest proportion with income greater than 150,000 per year, where Burmese households had the highest proportion, about 45%, with income below 50,000 per year. Now, in South Asian participants in the Masala study, cardiovascular health scores were higher in those with a higher versus lower income. And in the MESA study in the New York City Community Health Survey, Chinese adults were more likely to experience poverty versus white adults, potentially influencing their downstream cardiovascular health. Now, income may be uniquely related to cardiovascular health in Asian American populations in several ways. For instance, family income may be spread across a larger household size or a multi-generational household because of the high prevalence of multi-generational households among Asian populations in the US. So there may be some merit in indexing annual household income to household size to understand how many people a certain household income may be supporting. As well, the income-health relationship may be influenced in several U.S. Asian communities that frequently send remittances to family in home countries, where several Asian countries, as listed here, are among the top 10 remittance receiving countries from the United States. Educational attainment is another key measure of socioeconomic status, and here we see the distribution of educational attainment across Asian American groups, where Bhutanese individuals have the highest proportion of a less than high school completion, and Taiwanese individuals in the US with the highest proportion with an advanced degree. Uh, Differences in educational attainment are related to many different factors, including migration histories, as well as linguistic, cultural, and social factors. In data from about 1,600 aggregated Asian participants from NHANES from 2011 to 2016, it was observed that lower educational attainment was associated with an almost 70% lower odds of having ideal cardiovascular health compared with higher educational attainment after controlling for age and sex. Now, education provides a protective effect, but the distribution of education among US Asian groups varies widely. So again, it's important to note that it's not appropriate to aggregate Asian populations into a single group when considering the potential interventions that may benefit the health of Asian individuals. Limited English proficiency also prominently influences cardiovascular health, in part through its effect on quality of care related to language concordance between patients and clinicians. Here on this chart shows the distribution of speaking English versus limited English proficiency across the diversity of Asian populations. In data from NHANES, Asian adults, again in aggregate, who spoke their native language at home most or all the time, were less likely to smoke, but had worse cardiovascular health measures of blood pressure compared to adults who spoke English most or all of the time at home. Now, I just mentioned the potential role of limited English proficiency and its effect on quality of care. So we also spoke about several aspects related to health system determinants, with focus on access, quality, and utilization, both in the scientific statement and in my own research program. This chart shows the distribution of health insurance coverage from any type of insurance across groups. Now, health system access among US Asian communities is related to many factors, including the approachability and acceptability of healthcare services, the availability and accommodation of the specific needs of populations, as well as the affordability and appropriateness of these health services. In 2019, private insurance coverage ranged from 62% for Hmong Americans to almost 80% for Filipino Americans, where Medicaid or public health insurance coverage rates ranged from 26% to Filipino to up to 40%, 35% for Hmong Americans. Now, prior research shows us that gaps in coverage or underinsurance among some Asian ethnic groups, including Korean Americans and Vietnamese Americans, are in part attributable to high rates of employment in occupations that less often provide health insurance coverage, such as occupations in construction, maintenance, transportation, or small business ownership related fields. Many of these upstream factors may influence the quality of care received by Asian patients in the United States. So these are data that my group evaluated from the American Heart Association's Get With the Guidelines Coronary Artery Disease Registry to identify differences in quality of care for myocardial infarction among Asian groups. This plot is data from patients admitted to a hospital participating in the registry with an acute myocardial infarction, or specifically an ST elevation myocardial infarction, or STEMI. And the data show the odds of experiencing a door-to-balloon time of less than 90 minutes. This metric, a door-to-balloon time less than 90 minutes, is a key quality metric for ST elevation MI. And we observed that there were differences in whether patients in various Asian groups experienced this door-to-balloon time less than 90 minutes, with Indian male and Filipino female patients less likely to experience this quality metric compared with white patients in the registry. Similarly, referral to cardiac rehabilitation is a key quality metric for a clinical guideline recommended treatment for patients who experience a myocardial infarction in the American Heart Association and other society guidelines. In this registry, patients who had a myocardial infarction in Asian groups, in several Asian groups, were less likely to be referred to cardio rehabilitation compared with white patients, potentially leading to suboptimal recovery post myocardial infarction and higher risk for recurrent MI among Asian populations. So the differences in quality of care experienced by Asian patients may also contribute to differences in disparities of cardiovascular disease outcomes for these groups. And as we think about the adverse outcomes from cardiovascular disease, focusing on optimizing the quality of care experienced by Asian patients may be one important approach to support the health and improve outcomes across these groups. Last, in this topic, I'll highlight a few aspects of how neighborhood, physical, and social environments may be related to cardiovascular health. Now, the most common measures of social environments include measures and constructs such as social networks, neighborhood social cohesion, social support, ethnic enclaves, which is the conglomeration or aggregation or high prevalence of people from similar ethnic backgrounds living in a particular space, neighborhood safety, and built environment. An emerging area of research is the size, quality, and behaviors of people within one social network, which growing evidence suggests may influence health behaviors among Asian Americans. Shown here are findings from an analysis we conducted from data from the Masala study of South Asian adults, which demonstrated that if a person had a social network member with high blood pressure or high cholesterol, they themselves were less likely to have good cardiovascular health, which suggested that the health of social network members is related to one's own health among this population. We'll speak more about social environment and social support when we talk a little bit more about intervention strategies. And so with some context to the role of social risk and resilience factors related to cardiovascular health in Asian Americans, I'll move to this last topic, which is to highlight potential strategies and interventions that may effectively and equitably prevent cardiovascular disease for Asian American individuals. Now, there have not been many randomized controlled trials for adapted prevention interventions in Asian Americans. A 2014 systematic review included 7 randomized controlled trials with mixed evidence for efficacy of the interventions for the limited number of interventions that did exist. This systematic review recommended several strategies for interventions for Asian Americans, including promoting rigorous study designs and objective measures, obtaining larger sample sizes for study, as well as cultural adaptation and individual tailoring of intervention strategies. Now, I had the privilege of contributing to this randomized controlled trial of a culturally adapted lifestyle intervention for South Asian adults with cardiovascular risk factors called the Saheli trial, which stands for the South Asian Healthy Lifestyle Intervention, where in Hindi, Saheli means friend. The PI of this behavioral intervention trial was Dr. Namrata Kandula, who's my primary mentor, who developed this intervention in partnership with community members. Shown here is the study design and findings as summarized in a visual abstract from the manuscript published last year in JAMA Cardiology. Among 549 adults with a mean age of 49 years, participants were randomized 1-to-1 to a group-based lifestyle intervention versus mailed written health education materials. The primary outcome for this trial was between group differences in cardiovascular risk factor change from baseline to 12 months. And the intervention was a 16-week group-based health counseling intervention that addressed adapted dietary pattern, physical activity, and stress management strategies. At 12 months, this trial showed that the intervention did not result in better weight, blood pressure, hemoglobin A1C, or cholesterol changes compared with the control group participants. Although I will note for context that the COVID-19 pandemic did disrupt trial activities in the middle of enrollment. However, one of the key strengths of this particular study was that the intervention was very highly culturally adapted through engagement with community partners. Although the intervention was not observed to result in better cardiovascular risk factor change compared with health education materials, this study provides valuable insights into the adaptation of interventions for the South Asian community. One of the aspects we learned was the role of social networks as facilitators to and barriers to health behavior change. We conducted a qualitative secondary analysis among 24 Saheli trial intervention participants and 3 of the intervention health educators to understand how social network members contributed to health behavior change, and we identified 3 key themes. The first theme was that Saheli intervention participants and their family members provided social support to one another for behavior change. This support was in the form of informational support from the participant to family members by sharing information learned during the intervention. And we also learned that participants and their families provided companionship for health behaviors. A few representative quotes from our participants included this one, which said, "I influenced my family a little in cooking, so we drastically reduced rice quantity." Or another participant who said, "My husband and I made a habit of eating this big bowl of salad before we started eating rotli and shak, which are traditional Indian foods. This cuts down on eating other foods." A second theme that was identified was that Saheli participants provided social support to one another in the group intervention setting. Participants provided companionship, emotional, and informational support to each other. So representative quotes from our participants include one from a participant who said, "With COVID-19, we're all walking in our neighborhoods, but we have a conference call on the phone. And then we say, I burnt this many calories or this many steps." Another participant stated, "The classes were very motivating. It was very uplifting and energizing psychologically to go and be part of this group." Now, interestingly, a third theme that was identified was that Saheli participants encountered resistance to behavior change from network members. We learned that social connections were not always supportive. Sometimes intervention participants reported resistance to change among their friends who they tried to incorporate into their behavior change activities. Representative quotes here include this one, where a participant said, "I noticed that a lot of us were not proactive. And if I had one wish today, I wish the word discipline would become a part of especially the Indian community." Another participant said, "I've been trying to tell some, maybe 4 or 5 friends that please join this, please do this. They think I'm neurotic. I'm not going to flog a dead horse, so I've just given up." Using these data to design strategies for interventions that incorporate social network members may potentially enhance the effect of strategies to improve health behaviors among Asian American and specifically South Asian American individuals. I've also used this information in my own clinical practice when counseling patients for cardiovascular health behavior change, like improving diet quality or increasing physical activity. I'll often ask patients whether it would help them to include a family member or a friend in the conversation. Now, I do this for all patients, but especially for Asian American patients. Finally, another aspect advancing the science of cardiovascular disease prevention in Asian Americans is my work to understand the earlier life experience of Asian American communities to identify strategies for prevention earlier in the life course. Supported by a K23 award from NHLBI, I'm leading the Masala 2G second generation study, which is an offspring study of South Asian young adults who are children of original Masala study participants. The mean age of these study participants is 30 years, and the objective is to identify the causes of early cardiovascular and metabolic abnormalities for South Asians at younger ages, to identify adapted strategies for earlier prevention of cardiovascular disease. This is the Masala study structure. The original Masala study of South Asian adults in the US began enrollment in 2010 to 2013, and participants were followed over the last decade. The Masala 2G second generation study, which I'm enrolling, is incorporating second generation South Asians who are the adult children of original study participants with the purpose of evaluating early metabolic abnormalities, social determinants of cardiovascular health, as well as qualitative contexts to adapt interventions for earlier prevention in this group. And I'm excited to share that we just completed enrollment of the pilot cohort in this study with some findings forthcoming in the next couple of months. In considering other avenues of evidence for health in Asian Americans, I'll briefly also mention the MOSAIC study, a new initiative from the NIH to better understand the health of Asian American populations, which will certainly expand our knowledge in this space. So the MOSAIC study is planned to be a 10,000 participant longitudinal cohort of multiple disaggregated Asian, Native Hawaiian, and Pacific Islander groups, which is funded by multiple NIH institutes and centers, and is enrolling in the Chicago, New York City, Philadelphia, San Francisco Bay Area, and in Hawaii. Eligible participants are adults aged 18 to 64 years who are not currently pregnant and not in active military service. And languages offered for participation in the study include Chinese, Korean, Vietnamese, and Tagalog. So for anyone who is interested in participating or interested in referring somebody to participate, I would encourage you to visit the study website or scan this QR code to learn more about the study. So we've talked a lot about cardiovascular disease epidemiology in Asian Americans, the underlying social and structural risk factors, and some evidence for mechanisms of behavior change and potential strategies for intervention for cardiovascular health promotion and CVD prevention in this group. So to tie this all together, I'll highlight some research gaps that remain and what new and ongoing challenges are relevant for Asian Americans. First, as the second and subsequent generation of Asian American grows, there's an important need to understand how cardiovascular disease risk is transmitted across generations, both related to and outside of genetics. Second, there's a growing burden of heart failure and stroke among Asian American populations that disproportionately affects specific Asian groups, such as the burden of stroke in Vietnamese individuals. Evidence for why this is occurring and how to prevent it remain to be understood. And speaking of, we need to generate evidence for interventions that build on the social context of Asian Americans to effectively promote cardiovascular health in these groups. And finally, there remains an important gap in understanding how to ensure sufficient representation of Asian American populations in research studies and clinical trials. So to summarize our conversation today, health and disease are not experienced uniformly across diverse Asian American communities, with a particular emphasis on the heterogeneity and clinically significant variation in cardiovascular health and cardiovascular disease outcomes across diverse Asian American groups. Multi-level risk and resilience factors unique to the Asian American population may be potential avenues for intervention, and there's more work to be done to understand what the mechanisms are between these upstream social risk and resilience factors and downstream health. Effective cardiovascular disease prevention interventions may build on social support structures within South Asian communities, which is some of the work, based on some of the work that I and many of my colleagues have done in understanding the social contexts of Asian American populations. And the emerging second generation Asian American population experiences high prevalence of cardiovascular risk factors, so early prevention is key. As I conclude, I'd like to acknowledge the many, many people who have supported this research and my career development over the last decade or more, with particular thanks to my mentors and sponsors at Northwestern, including Dr. Namratha Kundula, Dr. Mark Huffman, Dr. Sadia Khan, and Dr. Don Lloyd Jones, as well as many others and many sponsors, including Dr. Clyde Yancey. I have many collaborators, research team members, trainees, and especially the study participants who help advance the science of cardiovascular disease prevention for Asian Americans. And so to all of them, I'd like to convey my sincere thanks. I thank you all again for the opportunity to share the work of my research group. I thank the Office of Disease Prevention for this recognition, and I welcome any questions.
Thank you, Dr. Shah. Very interesting presentation. We have a number of questions that have come in from our listeners, and I'll get started on those now. Going back to early on in the presentation, how widely are the 6 Asian populations that you identified in some of your early slides? How often are those actually identified in national data sets, and when did that start happening? If it's only recent, it may be very hard to look at patterns over time. But is this something that's pretty consistent, at least now?
Thank you for that excellent question, which I think really informs how many of us conduct research in this space. So the inclusion of Asian populations in national data sets certainly is variable, and there are some national data sets that do this much better than others. So for example, the National Health Interview Survey, which is a survey based on self-reported data, has included individual Asian groups for actually several decades. In an earlier slide, you may have seen that I presented data from the Chinese, Filipino, and Indian American groups. And those are the groups for which the data are most robust in the National Health Interview Survey. Many of the other groups are aggregated into a single category in NHIS. So a strength is that there's much more longitudinal data in the National Health Interview Survey. But a limitation is that many of the groups are still lumped into are lumped into a other Asian category that includes Korean Americans, Vietnamese Americans, and Japanese Americans kind of lumped into individual categories. Other national data sets have other important strengths and limitations. So for example, the National Health and Nutrition Examination Survey has specifically identified and included Asian participants since 2011. So that's only just a little bit more than a decade of data in NHANES, and the NHANES 2021 to 2023 cycle was only relatively recently released. Um, it's not that Asian participants were not included before 2011, but those participants were included into a group that was labeled as other. So it wasn't possible to identify Asian participants in NHANES before 2011. Since 2011, NHANES has made publicly available the aggregated group data for Asian participants. Um, and so because now about 10 years of data are becoming available, there is an increasing ability to evaluate trends in health status. As many of you may be aware, and the particular strength of NHANES is that it is not exclusively based on self-reports. So there are biospecimens collected and anthropometric measurements collected to understand things like blood pressure, blood lipids, blood glucose, to diagnose specific health conditions and cardiovascular risk factors. However, one of the biggest limitations of the NHANES data is that the disaggregated data for individual Asian groups, including the 6 groups that are the largest in the United States, the 6 Asian groups that are the largest in the United States, are still restricted access. And so one has to go through a proposal and approval process and access the data through a federal research data center in order to actually use data and evaluate data from individual Asian groups. Now, I will say, and this is just a personal opinion, I'm really glad that these data are available in NHANES, but it is very challenging to gain access to them. And for brief context, I've been working on a project to evaluate hypertension in disaggregated Asian groups through NHANES. And this project is now going on almost 4 years to get the data and do the analysis. And it's not an inexpensive project. And so to the extent that the data are available, that's a good thing, but there are still many barriers to access data. Um, the last thought I'll share is that I've not really seen any national level data sets identify Asian groups beyond those 6 largest Asian groups. And so as those other populations grow, there's more work to be done to enhance the representativeness of national and federal data sets.
Thank you. A quick follow-up. National data for at least these 6 groups are available for at least recent years. What about other sources of data, even if they're not national? For example, healthcare systems. Are there healthcare systems that have data available that are disaggregated at least to the 6 categories and maybe even to a larger number of categories? I'm thinking of some of the larger health systems around the country that researchers can access their data.
That's an important point, and it is in fact where a lot of the most clinically relevant data for Asian American populations is emerging. So the short answer is yes, there are health systems that have data on disaggregated Asian populations and patient populations that facilitate the ability to ask research and clinical questions for health promotion in these groups. And they are located, as you might expect, in the regions that have the highest proportion of Asian populations. And most prevalent that occurs in California and the West Coast. So the health systems that I've seen the most robust data include the Kaiser Permanente system, both Kaiser Permanente in Northern and Southern California, as well as health systems in the San Francisco Bay Area, like the Palo Alto Medical Foundation and Sutter Health, as well as within other health systems in the SF Bay Area. These health systems do allow patients to identify in disaggregated Asian groups, and they have really large patient populations with data spanning multiple decades. And so EHR-based data for Asian populations is feasible for research, particularly in California, and Kaiser also operates in the Pacific Northwest and in Hawaii. And so there are data available from those regions as well. But an important consideration is that the top five states in the United States that have the largest Asian American populations are not all on the West Coast. Of course, California has the largest Asian American population, but other states that make it to the top five include New York, Texas, and New Jersey. And although individual health systems may disaggregate data, there is not a lot of data that has emerged from health systems in these spaces. I know of several colleagues who are starting to work towards that kind of access, registry-based data in clinics, for example, in Texas health systems. A colleague of mine is working on those data. So I would imagine with time, these data will become increasingly available. But we are still in an environment where the regionality of data for Asian American populations is can be somewhat sparse. And I think this matters because the experience of Asian American populations in California, for example, may not be the same as populations on the East Coast or in Texas. And so that regional variation is something that has yet to really be investigated.
Thank you. Over the last 10 or 12 years, NIH has invested increasingly in what are called pragmatic trials, often conducted through health systems, where clinics or physicians may be randomized to study arms, and then the patients seen in those clinics or by those physicians receive an intervention based on the arm to which their clinic or provider was assigned. It's a type of group or cluster randomized trial, sometimes run in a parallel design, sometimes with a step wedge design. These kinds of trials are commonly used to evaluate interventions designed to change the way that healthcare is delivered in those healthcare systems. They tend to be more efficient than start from scratch to recruit and intervene with populations as we have done for decades at our academic health centers. So there's a lot of interest in this kind of trial at NIH. And it seems like it might be possible to address some of the issues that you've identified with suboptimal care in some Asian populations using that kind of approach. And I wonder what your thoughts are there.
Yeah, I think that's actually a really insightful view on how best to optimize clinical care and quality of care for Asian populations, because one of the challenges is that although the Asian population is growing, individual level enrollment in trials can be challenging, especially in part related to the regionality of where Asian patient populations may be located. And so I think randomizing at the level of a clinic or a hospital, both to kind of give broader scale to the potential regionality of the Asian population, as well as to answer important clinical questions about optimizing care quality, would really benefit from these kind of novel and innovative study designs that move beyond individually randomized trials.
Thank you. There are a couple of questions or comments about the Sahaley study. One, the Sahaley study emphasized culturally tailored interventions. What are the current challenges in scaling such community-based programs for diverse Asian American subgroups, and how can they be overcome?
Yeah, that is, I think, perhaps the million-dollar question, not limited to only Asian populations. The focus on scale and the question about scaling and intervention is a really important one. And I'll speak to my understanding of the experience for the Sahaley investigators, acknowledging again the tremendous amount of work that my mentor, Dr. Kandula, put into developing the intervention, because part of the work that she led was not just about adapting the intervention, but developing strong community partnerships to consider the question not just about testing the intervention efficacy, but also understanding what the implementation and dissemination opportunities might be. And so the study was conducted in partnership with local health systems, a local health department in a community with a high proportion of South Asian individuals. And especially if the intervention were found to be effective, those were the venues through which some of the community scaling of the intervention program may have been deployed. But I think the really kind of important point is as a researcher, that really means that in developing an intervention, I think the two important points are number one, community engagement and community partnership from the very beginning of the study, even before an intervention is designed, is critically important because I think as an academic, we ought to be thinking not only about whether the intervention works, but if it works, what are we going to do for that intervention to bring it to the people who would benefit from it? But also just not just about not using community engagement for the adaptation of the study, but also understanding the implementation and dissemination. And so it's through these established partnerships by which I think any intervention can potentially be effectively disseminated into communities that may need it. But I'll acknowledge that establishing these partnerships takes a lot of time, requires a lot of trust between academic organizations and community organizations and individuals who live in the community, and requires continual investment into that relationship. And so the brief response, I think, is that, or the summary of the response is that the only way that I think implementation and dissemination can work is through strong, effective, and trusting community partnerships where community representatives are an equal part of every stage of the research design.
We spoke a little bit about the use of healthcare systems as a way to reach Asian subgroups and deliver interventions. Are there some other channels that you would suggest? You know, when I think about school-based studies or community-based studies, you know, you're not going to have concentrated Asian populations that you can reach that way, but you may have some ideas about other methods for reaching these population subgroups.
Yeah, what an interesting question. I think your question really speaks to meeting community members where they are and thinking about what the community spaces are where people of Asian ethnicity, or really any group, spend their time. You know, this reminds me of this study, as many of you may be aware, that was published a couple of years ago in the New England Journal of Medicine, that has sometimes been called the Black Barbershop Study, where a cardiovascular health promotion intervention was deployed in barbershops where individuals who identified as Black spent a lot of time and were kind of trusted community spaces to deploy a health promotion intervention. So similar community spaces, not necessarily a barbershop, but similar community spaces may be of potential value in meeting individuals in Asian communities where they are. And there's been interest, for example, in the South Asian community in evaluating the role of religious or faith-based organizations, temples and mosques, for example, in being a community space in which health promotion may occur, not only because it's a space where people maybe spend a lot of their time, but is a place that is kind of considered a trusted community space. But you know, I will say, and I'll certainly caution that any effort to incorporate any kind of intervention in this or any kind of community space, once again, requires quite a bit of engagement with organization representatives, faith organization leaders, as well as members of the community who may attend services at these locations. So it's not really a fast opportunity, but it may be one that could be potentially fruitful.
Thank you. We have reached the top of the hour, so I'm going to be forced to wrap things up, even though there are many more questions. I want to thank you, Dr. Shaw, for a wonderful presentation, and I want to thank our participants for excellent questions. As I mentioned earlier, we will be posting the slides and a recording of today's presentation on our website in the next few weeks. I want to thank everyone for joining in today's lecture, and I also want to draw attention to the fact that we have a second early stage investigator lecture tomorrow, also at 10 o'clock in the morning, on unpacking the influence of e-cigarette marketing features. And we have the third one on Friday afternoon at 2 o'clock on type 1 diabetes management in the US. If you're interested in those, you can go to the ODP website and find the registration site. We look forward to seeing you. Thanks very much for your attention today.